Okay, so plan for today, we're gonna do a lecture on type 1 diabetes, go through mainly insulin management, the big thing for today. When we're done, Dr. Lock Valentine is teaching today for gynecology for you guys. She's in a meeting right now doing a presentation. So there was a brief lecture I was supposed to give you guys during neuro. It's not a big deal, it's just a side lecture. If you want to stick around for it, you're welcome to. It's not required. The lecture is on medical marijuana and its uses. Obviously, a lot of the uses are for neuro related when it comes to like state of Florida and getting approved for the medical cards. So I'll go over that. It's a quick little lecture. If you want to stick around for it, you're welcome to. If not, you're on break. So for now, we'll do type 1 diabetes. Why is this not? Let's see what happens. Okay. So our objectives for today. So overview, type 1, multi-system disease, affects a lot of different things. It's a disease of carbohydrate, fat, protein, so all of our macronutrients. In type 1, again, insulin is absent because of all the destruction of our beta cells, most commonly in juveniles, but it can occur in adults in that 30 to 40 range. And generally, people with type 1 are not obese. Okay. Okay, so pop culture is making type 1 diabetes more relatable. So here's American Doll, and they have all the type 1 gear and all that stuff with it. So it's part of accessories. So it's again normalizing seeing kids with insulin pumps or glucose monitors and whatnot. This is from Red Panda, I think it was the movie. The girl has the pump right there, or the glucose monitor on her arm. So they're making comments about that. If you ever watched this show, Caillou? So there is we're gonna watch this. Hopefully this time. Hey, miss. Hang on, the sound's not working. You guys hear that? get the idea. We'll stop. Anyway, here's some famous people with type 1 diabetes. Okay, so, who's that? Anyone know who that is? He's a swimmer. He's Olympian. She's a Supreme Court Justice Sotomayor, and then you know who that is. Okay. Okay, so catabolic disease, so it's breaking down things. Okay, catabolic breaks things down. Circulating insulin very low or absent. Glucagon goes up because nothing is opposing insulin release. Remember how insulin suppresses glucagon. When insulin is released, it bathes across those alpha cells and turns them off. There is no beta cells making insulin, so nothing is turning off the glucagon, so glucagon goes unopposed. If glucagon is unopposed, what's going to happen to their blood sugar levels? Up and up and up and up and up. Now, the beta cells don't make insulin, but are their tissues responsive and sensitive to insulin? Yes. So you're going to see for type 1 diabetics, they don't require very much insulin compared to a type 2 diabetic. We'll talk about a little bit later on. So they need exogenous insulin because they aren't making any other on their own. It's an autoimmune disease, and it just destroys all those islets of Langerhans that have all the beta cells in it. 85% of patients will have a circulating islet cell antibody. Again, it's going to attack, if these are autoimmune diseases, they're going to attack the beta cells and destroy them. Also, it may have detectable anti-insulin antibodies. So you may see those as well. Another one you may see are these antibodies against glutamic acid decarboxylase. So these are three things that you may see with type 1 diabetics with regards to looking at antibodies. So when one patient in a family gets diagnosed with type 1, they screen the other ones to see if they have any of these antibodies floating around. That's what they're looking for. Autoimmunity obviously is a major factor. So one of the things we're going to deal with, I think it's in this picture. No, it's the next slide. So we know that there's usually going to be a preceding infectious or environmental agent that kind of started this whole autoimmune cascade to start. So whenever they present in the hospital with DKA or you diagnosed with type 1, ask them, were they sick recently? Any recent illnesses? Okay. No, not a good one. You guys aren't funny anymore. So in our next unit of endocrine, in the second part, we talk about the other endocrine disorders. One of the things we're going to talk about are called multiple endocrine neoplasias. These are a host of diseases, all deal with autoimmune problems, but they're going to present with type 1 diabetes, and they may also have Graves' disease or Hashimoto's thyroiditis, or even Addison's disease. They may have a bunch of different ones. In the next unit, we're going to go over 4 of them, and there's different combinations of what happens with them. So we'll go over that next unit. But type 1 will pop up again because it's an autoimmune problem. And then here are the environmental agents, viruses, toxic chemicals, cow's milk in infancy, and some cytotoxins can lead to type 1 diabetes later. Vitamin D is also very important with diabetics, type 1 and type 2. So obviously get in the sun. If they can't get in the sun, then get vitamin D through other ways. 5 to 10% again of all diabetes are type 1, most commonly in childhood, and then later on as they get older. 1 to 2 million Americans have type 1, and about 15,000 new cases each year. Scandinavia, highest prevalence for type 1. China and Japan have the lowest for type 1. 20% of the people with type 1 diabetes, have some sort of Scandinavian descent in their genetic history. Type 1, more common with non-Hispanic whites, followed by African Americans, then following Hispanic Americans. Again, uncommon among Asians, more common in men than women, and usually young children, adolescence is when this starts happening. And people late 30s with that late autoimmune diabetes later on. Morbidity, mortality, same thing. Again, these are uncontrolled diabetics. Type 1 diabetes is not reversible. Type 2 is, as long as they stay non-insulin dependent. But all diabetics will have the same problems if they're not controlled with their sugar. So complications, heart disease, here's your strokes, peripheral vascular disease, renal problems, vision problems, and obviously all of our autonomic issues as well. Type 1 or type 2, they're going to get the same issues if they don't take care of themselves. So again, tight glycemic control is always the number one thing for these diabetics. Control of other comorbidities, such as hyperlipidemia if they have it. So all we're trying to do is primary prevention. We want to prevent that first incident from happening with these patients. Clinical presentation, history. Here's your polyuria, polydipsia, polyphagia, may have some fatigue, nausea, blurred vision. And again, all of these are due to the hyperglycemia that they're going to have. Again, they may present with ketoacidosis and explosive onset of symptoms in a young lean patient with ketoacidosis. So they normally should not have it. Any young person coming in, altered mental status, and you do your ketone level and they're showing very, very high, there's got to be a reason for that, most likely type 1 diabetes. The polyuria and thirst due to osmotic diuresis, thirst due to the hyperosmolar state, all the extra glucose and ketones that are floating around now makes our thirst drive go up. Polyphagia with weight loss. They're going to be eating and eating and eating. Remember, this is a catabolic disease, breaking things down fast. So they're going to be eating, but they're going to be losing weight. Fatigue and weakness, again, from this catabolic state. Insulin deficiency, hypovolemia, and hypokalemia. Blurred vision due to the hyperosmolar state, the way it affects the vitreous humor. We get blurred vision that way. GI problems, some nausea, abdominal discomfort. If they have any incidents of acute fatty liver, that will lead to some right upper quadrant pain due to the capsule getting distension. May have some persistent abdominal pain, maybe due to DKA. And chronic gastrointestinal symptoms are a later stage of diabetes, and that's really due to that autonomic neuropathy that develops with these diabetics who are, again, uncontrolled. Peripheral neuropathy, we've already gone over. Remember, it's a stocking glove pattern, hands and feet. Remember the distribution of how these patients start with these peripheral neuropathies. It's bilateral, symmetric, ascending. Remember, we went through all those things with neuro, which ones are ascending, which ones are descending, and stuff like that. Nocturnal enuresis. This is usually one of the signs of a patient going to be having type 1 diabetes. Because usually younger, obviously your baby, infant, you're wet the bed, but then you grow out of it and you become potty trained. But then all of a sudden they're like 10, 11 years old and they start wetting the bed again. If you have a patient, pediatric, start wetting the bed again later in life, I'm not saying it's always type 1 diabetes, but it could be, it's definitely under differential type 1 diabetes. And again, whenever they first started, trace it back several days and weeks, there's going to be an antecedent event, some infection. But the beta cell destruction may have been going on for months or even years. Remember, you have to have a good percentage of these beta cells destroyed before you start getting clinical symptoms. Just like with the renal system, you have to have a certain percentage of nephrons to be destroyed before you start showing signs of renal failure. Same thing here. In new cases of diabetes, physical exams are often normal. If they're presenting with DKA, obviously they're going to have the signs and symptoms of DKA, the Kussmaul breathing, dehydration, hypotension, altered mental status, very common, going to be seen a lot as well. So again, these don't change if you're type 1 or type 2. A1C 6.5, fasting glucose 126, a 2-hour glucose in a glucose tolerance test of 200, and then 200 in a random with symptoms. So 6'5", 126, and 200. Only three numbers you got to know for diabetes. There's no super diabetes. If you're higher than 6.5, you just diabetes. There's no stages for it. Other diagnostic labs you want to do, check your electrolytes, get a UA, check for glucose, ketones, and proteins. That'll tell us if we're already getting any kidney issues from their uncontrolled diabetes. Urine ketones are not reliable for diagnosing or monitoring DKA. It's the blood level that matters. Remember, the urine doesn't care. They're just getting rid of stuff from the body. Plasma acetone level is also done. It's based in the form of this beta hydroxybutyric level or butyrate. I think it's on a lab, it'll be BOH. It'll look like that on a lab. Beta hydroxybutyrate is a hallmark of DKA. And check your white blood cells and urine cultures just to rule out any infection that can also be causing them to have these problems as well. Insulin levels below 5 international units or microunits per ml. Obviously, they're going to have no insulin being made, so you're going to have very low insulin numbers. Here's your high positive titer of that glutamic acid decarboxylase, the GAD antibodies, also indicative of type 1. And look for your islet cell or insulin antibodies, the antibodies to the actual insulin or the beta cell itself. The antibodies may be present before the onset of clinical symptoms. Just because they have the antibodies there doesn't mean they have the symptoms and problems already. Treatment, the only treatment is insulin. There's nothing else. You have to give them insulin. They're not making any insulin. You give it to them, they'll be okay. So the way that there's two basic ways to do this. Lady may say she does different things because she's been dealing with so long, but when you're having to go through the first time, you have to figure out how much insulin do I even give this person? How do we start? And then how do I know how much to give during meal times? How much to give to correct all that stuff? So we're going to go through all this as we do this next section. To control hyperglycemia and electrolytes and hydration, that's what all the insulin is going to be there for. So first thing we do is the weight of the patient. We start there. Then whatever dose that we come up with, we're going to divide that in half. And half of it will be basal insulin, which is long acting. It's going to stick around all day. Then we give prandial insulin. The other half gets divided out. We have to give you insulin because when does insulin come up? When does it rise in the body? When you eat something. So you have to count for all the carbohydrates that you just ate in the meal, and you have to correct for that as well. And then after you do your dosing, adjust the amounts and types, the timing depends on the glucose levels. This is your goal. You want before every meal, and these type 1 diabetics should be checking their glucose before every meal. I won't ask Lainey, but 80 to 150 is the goal. That's your goal before every meal for a diabetic. If they're higher than that, you got to adjust the dosing from there. Now, how do you adjust insulin dosing? Increments of 10% at a time, and you assess for 3 days before making any change. You want to see how their glucose responds to the change in the insulin dose. So you will have calculations on this test. They'll be very easy, like divide 3 by 12, like that type of math. The calculator will be there just in case, but math will be there. I will tell you on the exam what the conversion is. I will tell you, so for example, for insulin naive patients, these are people who have never taken insulin before. Obviously, they're going to be very, very sensitive to insulin, so you don't need much. If they're underweight, older age, or on hemodialysis, you just give 0.3 units for every kilogram of their body weight. Obese, insulin resistant, and they're taking glucocorticoids, now you're up to 0.6 units for every kilogram body weight for that patient. I will tell you this conversion. I won't say just guess which one on the exam. So that's kind of how we figure out what our total daily dose of insulin is, TDD. This is just going to tell us how much insulin they need in a day. So let's assume we have a patient who weighs 200 pounds. You convert it to kilograms by divided by 2.2. So this person weighs 90 kilograms. And let's say it's normal weight, so 0.4 units per kilogram per body weight. So for this patient, they require 36 units of insulin per day. Everyone follow this point? Yes. Well, it's going to be total everything. So basal is half of that. So 36 units of insulin is required for that patient per day. So let's talk about insulin schedules. There's two ways to do this. One, you do injections, or you have a subcutaneous infusion pump. We'll talk about mainly the injection ones. The infusion pump kind of does its own thing. Multiple subcutaneous insulin injections to control the hyperglycemia after meals and maintain normal glucose throughout the day. It will increase the risk of hypoglycemia. You're giving someone insulin. Obviously, the risk goes up for having a hypo event if you give too much, or we'll talk about in a little bit, if you dose yourself of how much you think you're going to eat, and then your girlfriend steals half your food, but you already gave yourself all that insulin, but you only eat half the food. You're going to bottom out. You're going to hypo out. You got to eat all your food for whatever insulin you gave yourself. It's going to go away. So 40 to 50% of that total daily dose is a long-acting insulin at bedtime. And then you give additional doses of the rapid-acting or short-acting insulin for meals. The rapid-acting insulin kind of acts like your normal endogenous insulin by acting fast, getting out fast, doing its thing, and getting out. Patients may need additional intermediate or long-acting insulin in the morning for all-day coverage. Again, depends on their glucose log. So every time you see these patients, they have to bring their glucose monitor, and you got to check to see all their levels. And they should adjust their daily dosages based on the self-monitoring of glucose. That is, if you ever heard of a sliding scale, that's the sliding scale we're going to get to in a little bit. Okay. What? Go ahead. Okay, let's go back to our patient. 36 units of insulin per day is what they need. 50% is a basal dose, usually at night. So therefore, that patient is going to get 18 units every night. They're going to inject themselves 18 units at night of long-acting insulin. The other 18 units are divided out with each meal with the rapid acting or short acting. So you get 6 units with your breakfast, 6 for lunch, and 6 for dinner. And there's your 36 units of insulin for the whole day. This is a starting point, just so you know where to go. We're going to go through a little bit more advanced ways to do it, but this kind of gets you started for your meals and what you're eating. So this top part up here, this is injections of insulin. So the long blue line is glargine, which is a long-acting insulin, and this is when they injected it right there. And it's starting to build up in the system, and then it gets to a basal level in the blood. And that glargine will stay there all day until it starts to wear off, and you take another dose. Then you have your boluses for your mealtime, breakfast, lunch, and dinner of short-acting insulin, depending on whatever you ate. The second line is Detamir, which is a intermediate-acting insulin. It does not last 24 hours, so they take it twice a day, once in the morning and once at night. This is intermediate-acting insulin. And again, you still do your boluses for your meals. The bottom one is infusion. Okay, so Lainey, you have an infusion pump, right? So her pump is filled with rapid acting insulin. She does not need basal because the infusion pump acts like a pancreas. So it's constantly giving her a little bit of insulin all the time. And then when she eats food, she pumps in there how many units she needs for the food that she ate. And then the device will bolus the rapid acting for her to take into account the meal that she just ate. And then every meal, she'll just pump in how many units I need, and she boluses herself. Because it's an infusion, it's constantly being infused. It's always going to be rapid acting insulin. The rapid acting is going to be fast. The long acting will be too long, won't do anything. So these are the two ways for prescription for type 1 diabetics. Now, this is a sliding scale. There are two ways to look at this. We have the AC and the HS. What is AC? Before food, anti-consumption. Food. So before you eat, you check your blood sugar. Let's say, we'll use Lainey as an example. She doesn't care. So let's say Lainey was a good type 1 diabetic. She checked her sugar before she ate lunch. Did you? For real? Okay, good. So let's say her sugar was 225 before she ate. What's the goal before eating for every diabetic? 80 to 150. So you see, anything less than 150, you don't need to correct for because you're already controlled. All you need to do is just give you some insulin for the food that you're about to eat. Now, let's say Lainey's sugar was 225. She is highly insulin sensitive because she's type 1 diabetic. So she needs to give herself 2 units extra to account for the blood in her system before she even ate anything. So you have to correct that first, then give extra depending on the food that she ate. Isn't this fun for type 1s? It's a lot of work. Okay. So if she was normally insulin sensitive, most patients, then you can go to 4 units to correct for the sugar in the blood before she ate. HS, what's that? Hour of sleep. So at bedtime, we check it again. We don't give much, but if their sugar is really high, we have to correct for that as well. So when they go to the hospital, any patient that goes into the hospital who's admitted to the hospital, ideally you want to get them off any diabetic medications, oral medications, and just give them insulin in the hospital. Why do we do that in the hospital? A lot of these diabetic medications, what do they have a problem with, or maybe they have issues with? What system? Kidneys. So if they're going to the hospital, odds are they're going to need some sort of scan possibly or something. So to kind of like prophylactically like calm the kidneys down, all diabetic patients that come to the hospital, we put them on a sliding scale and we give them insulin to correct whatever they ate. They go on insulin while they're in the hospital, discharge, they go back on their oral medications. On your exam, I will tell you exactly what the scale is and how much you need to give. So look at the rates and you'll look at the scale. Okay, I need to give this much and then this much. Any questions on sliding scales and how they work? Yes. Mm-hmm. Or type 1s. Type 1s are going to be on very low doses of insulin versus compared to type 2. You'll see when we calculate it out. So now, how do we know how many units of insulin to give for how much food that you ate? We don't know. You have to know how many grams of carbohydrate. So we do a calculation called the insulin carbohydrate ratio. Using the rule of 500, what we do is we take 500 and divide it by the total daily dose of insulin that we calculated a while ago. And that means it gives us a ratio for how many units of insulin to cover how many grams of carbohydrate. So for the example, Total daily dose was 36 units. 500 divided by 36 is about 14 units or 14 grams of carbohydrate. 14. What that means, for every 14 grams of carbohydrate that she's going to eat in her meal, she needs to give herself an extra 1 unit of insulin for every 14 grams of carbohydrate. So when you then add this amount to the correction scale, this gives you a more sensitive number than what we did before. We just said just take 6 units every meal. Some people get in the habit, Lainey maybe at this point, she just gives herself, she knows how much units to give herself, and then she's fine. Some people need to be very specific as far as detail of how many units, depending on. So if you take this number, add it to the sliding scale, and that's how many units they need to give themselves with every meal. That's why they have to check their glucose before they eat, to accommodate the food that they're going to eat and the sugar of the blood already. Yes. They're either or. Either give themselves 6, or the more sophisticated way is knowing what your glucose is before you eat and this ratio. So let's take this example. Pre-lunch blood glucose is 230. Sliding scale states take 4 units to take care of that extra glucose in the blood. Patient wants to eat a 6-inch cold cut combo from Subway. That sub has, I just picked, Subway's on the street. That's why I need something fast. Something that had units on it. This is why they give, if you look at your nutrition facts, like diabetics love it now because, oh, this is perfectly, it's 40 grams of carbohydrate. There you go. So the patient's insulin carbohydrate ratio is 1 unit of insulin for every 14 grams of carbohydrates you're going to eat. So 40 grams of carbohydrate, 14 gives us a ratio of 3 units. So this person needs 3 units for the meal they're going to eat to cover all those carbs in the meal, plus the 4 units to correct the current blood sugar. So they should take 7 units. You see, we're not that far off. Originally, it was 6 units. We're 7 units. It's not that big of a deal. But do you understand now? This person bolused 7 units thinking they're going to eat a 6-inch cold cut combo. And again, if you don't eat the whole thing, your partner steals half your food, you're going to bottom out, because that's why they need extra snacks, because you're giving yourself too much insulin for the amount of food that you ate. Insulin's going to do its job anyway. You're going to bottom out, feel like crap, have a hypo event, you need more food. Yes. You can do it once you eat and it's fine. Sometimes they do it before, sometimes afterwards. Like that big of a deal. Like 20 minutes, not going to do anything. Yes. Another question? Yes. Oh, it's not that big of a deal. So that's how it works. Yes. Chris, you have a question? Uh-huh. No, I mean, that way, obviously, are they having an event in that, or they're still like walking and be fine? Then they go to the hospital. You got to dilute them out, give them insulin, they'll break it down. But that's an emergency case. But basically, that's how you're supposed to calculate every meal as a diabetic. So welcome to the world of a type 1 diabetic. Okay. So that's injections. The other way is the subcutaneous insulin infusion. And again, that's always going to be rapid acting insulin in that device. Selected program basal rates of insulin. So it's always going to be dumping a little bit of insulin throughout the day. Yes. Yeah. Oh, you take 40. Oh, wait a minute. It's the last line. Same person. 1 to 14. Yep. So that will always, that never changes. That ratio, once they know what their ratio is, unless their like total daily dose changes, then that won't change. So patient self-monitors preprandial glucose levels and adjusts the boluses from there. Obviously, if they have a continuous glucose monitor, it's even easier because you put your phone to it and you get your reading and you move on from there. Better control than with multiple injections. So pump is best. Hypoglycemia is common at first with pump therapy because you're trying to dial in. Lane, did you have any problems when you first started the pump? Any hypo events when you started getting used to it or not? Okay. So you have to get used to it, figure out maybe you have too much insulin, too little, or maybe eat more, figure out from there. But once control is achieved, it's the same as multiple injections and they do just fine. So who would you want to give a pump to? Obviously, what's the biggest limiting factor with the pump? Do you think it is? Cost and money to pay for it. But who would do very, very well with the pump? People who have hemoglobin A1C greater than 7 with frequent severe hypo events. So they're not very well controlled. They're bouncing from both extremes, too high and too low. Patients who have hypo events that require third-party assistance. They're taking too much insulin, they're bottoming out too much. So the pump will help even things out, reduce these hypo events. Any patient with frequent or unpredictable fluctuations in glucose levels, they bounce around. They would do very well with a pump as well, and perceive that diabetes management impedes the pursuit of personal or professional goals. People don't want to inject themselves 4 times a day. They want to, so here's a pump. You can use that. You don't have to worry about doing anything. How often you got to change the needle for that? Every 3 days. So you got to change the needle. Does it hurt going in? No, after a while, you get used to it. It's a very, very thin needle. It just goes around subcutaneous level. So that is the pump. And this is what it looks like. Goes right in. Put a sticker over it. Fine. So now let's get into the actual insulin. Because nothing else is going to be there. They're all taking insulin anyway. Subcutaneous first-line therapy for type 1. There are different types based on the time of onset and the duration of action. How fast do they work and how long they have an effect for. So we have short, intermediate, and long-acting insulins. Human insulin currently is the only species of insulin available in the United States. Rapid, short-acting insulin, most rapid onset of action when you need it quick. So glucose is over 250, give it quick, it'll bring it down. Intermediate, long-acting insulins, slower onset of action, but a long duration. So that's why they're the basal ones. We give it once a day, should last you 24 hours. And again, usually administered in combination with faster acting. Again, so you have benefit of a single injection. Rapid acting insulins include regular insulin, Lispro, and Aspart insulin. Okay. Those are the 3 types of rapid acting insulin. Onset is about a half hour to an hour, peaks about 3 hours later. It doesn't last that long. So every 6 hours it goes away, which is about when you eat. Some of them come in these pens where you just twist the end and you dial up how many units you need, and you push the pen and you inject yourself. Or they may require the vials with the diabetic needles and they draw up how many units they need that way as well. So Lispro insulin or Humalog is regular insulin. Aspart insulin is known as Novolog. Don't worry about anything else, just know the names. Both of these are absorbed quickly and rapid onset. So they have the advantage, they can be given right before eating. So Lispro, Aspart, Novolog, Humalog, those are your rapid acting insulins. So I gave you a question on your exam and said you have to give 6 units of insulin for a meal. Which one would you pick? It's got to be one of those. This is an intermediate acting insulin. This is NPH, neutral protamine hagedorn, or Lente. And these are intermediate acting. These are like 12 hours. We'll go through the algorithms as far as when you change things and stuff like that in a minute. But again, just know the names of what they do. Are they long acting, short acting? There are mixtures of insulins. You'll see them as like 70-30 or 50-50. These are mixtures with different types of insulin, different onsets and different actions. So they can contain 70% NPH and 30% regular insulin. The 70% NPH, is that long acting or short acting? Intermediate. Well, intermediate, I'm sorry. So it's intermediate, it's not the short acting. Then the 30 is regular insulin. Is that rapid or long? Rapid. So you kind of give yourself a mixture of the long acting and the rapid together. So whenever you see like a Humulin 70-30 or 50-50, it's a long acting and a short mixed together. Here we're just talking about, again, just your insulins. Preparations contain about 100 units per ml, so that you have to draw it up on a diabetes syringe. Multiple dose insulin injection devices, those insulin pens, just a cartridge having multiple doses in it, and you can inject yourself multiple times with it. Most insulins are stable at room temperature for months, so you can leave them at room temperature. And we know what insulin does. Long-acting insulins include ultra lente, so that's easy to remember. Lente was the intermediate, the ultra lente is the long-acting one. And we have our insulin glargine or Lantus. So these are long-acting insulins. And again, 24-hour action. That's why they're once-a-day dosing, usually at night. We do have some extended ones. This is called ultra lente. Onset of action is 4 to 8 hours, but look at that duration of action over 32 hours. So people who want less injections, you have to give them longer ultra lente acting insulin. Yeah. Oh, yeah, it does have the same name. I wouldn't make a question like that, but it's still, you only give human, it's the U, I think, as the U at the end. Makes it the long one. Here is Detamir, Levemir. This is that twice-day dose, BID sub-Q, for people who require long-acting basal insulin for hyperglycemia control. If their morning insulin, their fasting glucose in the morning is too high, you need to increase the basal insulin, not the prandial dosing, it's the basal one. That's where that comes in. What's their fasting glucose levels? And obviously very, very long acting. So again, just sub-Q, Q-day, or BID dose. So you can see here, this picture here is regular insulin, fast acting, slow duration. Here's your ultra lente, nice gradual onset and peak, but it lasts a very long time. So again, just shows you differences between the rapid acting versus the long acting. Just characteristics, just know your insulins, your Lispro, Aspart, Glargine, Lantus, Detamir, Levemir. Just know those four. Other treatments. Simlin. Simlin is a synthetic analog of human amylin. Remember with type 1 diabetics, when these beta cells are destroyed, they lose amylin as well. Amylin is also produced in these beta cells, so they lose this as well. Amylin slows gastric emptying, suppresses postprandial glucagon. Is that important for diabetics? Yes. Postprandial glucagon, why that low? And helps with appetite modulation. Indicated to treat type 1 or type 2 in combination with insulin. You give it together. You don't just stop one versus the other. Give it before mealtime for people who have not desired, obviously, their control, and helps lower glucose after meals. Less fluctuations and when. The goal, less insulin use and a reduction in body weight is observed. So adding in the Simlin to the insulin helps as well. You go by the glucose reading. If they're not controlled, then you start adding more or increasing the insulin. You just go by the glucose readings. If their glucose readings are fine, don't change anything because you've achieved optimal control. Surgical care, they do have pancreatic transplantation in some people. They'll put pancreatic islets in different parts of the body that still have access to blood. They can sense glucose and they can release insulin. Yeah. I don't know about that because you're giving a different person. It's not your islets, it's someone else's. So I don't know if your body would attack them as a foreign one. I'm not sure about that one, but it's a possibility that they can do for treatment. Diet, obviously they have to manage their diet, but diet is not the reason for type 1 diabetics. Type 2 it is, type 1 it's not diet. It's important to keep their sugar controlled, what they're eating, but it's not due to their diet. So talk about timing, size, frequency, composition of meals. Anyone on insulin should get a dietary plan. Talk about caloric intake, how much of their macros they need, and how to divide calories between snacks and meals and whatnot. So get that diabetes educator involved. Exercise, keep exercise going, but be careful with this. Remember, after exercise, your muscles will absorb glucose on their own without insulin. So if they're going to be planning on working out, you have to tell them to reduce their insulin before they work out, because just the act of exercise will get rid of the glucose as well. So keep their hydration going, but they don't need as much insulin before their workout, and have them reduce it. Okay. Couple of things that happen with sometimes with diabetics. AM hyperglycemia. What's their fasting glucose? What's the goal for every fasting glucose in the morning? 80 to 150 in a diabetic patient. So there's two things that can cause AM hyperglycemia. The first one is called the dawn phenomenon. And this is the normal tendency of glucose to rise in the morning before breakfast. Why does this happen with the dawn phenomenon? Maybe due to nocturnal spikes in growth hormone. Okay, remember, growth hormone does what to glucose, blood glucose? Increases it. And when does growth hormone come out? At night when we're sleeping. So maybe it's be due to that. So they're having constant glucose release at night, and that's making their insulin resistance worse. Or probably enhanced by increased hepatic gluconeogenesis due to the rise in cortisol. When we wake up in the morning, right? Cortisol peaks and we wake up, our glucose rises. That's why they get AM hyperglycemia. That's one example, is the dawn phenomenon. Growth hormone or just gluconeogenesis from hepatic output. That's the dawn phenomenon. The next one is the Somogyi phenomenon. Again, they're going to wake up with hyperglycemia, but what the cause is different. With Somogyi, it's a nocturnal hypoglycemia with a rebound hyperglycemia. And what you're catching is the rebound hyperglycemia event. Why would someone have a nocturnal hypoglycemic event? What did they probably do? Too much insulin of their long-acting insulin at night. Remember, there's a peak of action. When does it start? That's why we take the long-acting at night. So it has its effect when you're sleeping. Because if you took it in the morning and it peaked and you're taking more insulin on top of that, you may bottom out. So we take it at long-acting at night. Yes. Yeah. So you have a nocturnal hypo event. To correct it, because you're sleeping, you have to dump sugar in the blood. So you get an AM hyperglycemia. It's a rebound hyperglycemia due to the nocturnal, due to blowing too much. It just, when you're sleeping at night, your blood pressure, your blood glucose drops on its own, secondary to the insulin that you took, or you didn't have a mealtime, like a snack before bed. That helps resist that. So there's a couple of things that have a snack before bed or reduce the long-acting insulin at night. Both the dawn and Somogyi phenomenon have morning hyperglycemia. The difference is Somogyi is rebound hyperglycemia. And both may be corrected by switching to intermediate insulin at bedtime. This is when you would switch to that intermediate, the twice daily dosing. Yeah. Not them purposely doing it, it's their body doing it naturally. They're not waking up. Nope. But you don't know why they have AM hypoglycemia. You have to figure it out. Yes. They will not wake up. They just wake up in the morning and they see their sugar is 170, 180, 200. Uh-huh. Yep. And you switch them to the immediate. So they do once at night and once in the morning. It's still basal insulin, just they don't act as long. More patient education. A lot of the stuff with diabetes is a lot of patient education. Especially with type 1s. It's a chronic condition, lifestyle modifications. They're going to be on insulin for life. There's nothing changing that. So again, be honest with them and say, this is what's going to happen. But let them know it's, it's correctable and you can lead a normal life. You just have to take care of yourself. And likely to have chronic complications if they don't take control of the disease. So again, uncontrolled hyperglycemia leads to problems. If you control it all, get your weight under control, again, the diabetes, not type 1, but type 2 will go away. Plasma glucose monitoring. How often should they check their blood sugars? They have to know how to self-monitor and record their glucose levels. Obviously, if they have a CBM or CGM, the continuous glucose monitor, it'll do it all for you. Just get your phone and you show your doctor and you can see it all yourself. They should do it 4 times a day, one before each meal. So one in the morning before breakfast, lunch, dinner, and at bedtime. Increased bedtime doses of hypo agents with nighttime peaks may correct early morning hyper events, but may have this nocturnal hypoglycemia. We talk about that Somogyi phenomenon. If they're well controlled, they can get seen every 3 months. They don't need to be seen that often. Talk about the disease process with the patient, management goal, long-term complications, numbness in the feet, vision problems, kidney problems, bring it all up. Again, talk about hypoglycemia with them so they understand what are the symptoms like, what are they going to feel like, how to fix it. In summary, obviously we'll go through this at a different time, but the different algorithms, we'll go over the algorithm after we do type 2, we go over the oral stuff. And there's our review. Maybe everyone. This is a former student as well. He sat back there. He had type 1 as well. He was the first one that I went on the picture. So I've had like 3 or 4 of them. So take a break. If you want to come back at 2:30 for Dr. Valentine, you're welcome to. If you want to stick around, you can as well. Take 5 minutes and come back at 2:30 or 1:30 if you want to stick around.